Okay, thank you very much, Mr. Chairperson. Ladies and gentlemen, good afternoon. It is my great privilege to have an opportunity to be a speaker in JHRS 2023. My disclosure information. Let me start to show the Yonsei AF population cohort data first. This is Kaplan-Meier curve for AF recurrence after catheter ablation in my institute. And over 5,700 patients experienced 1-year outcome. It looks pretty good. However, as patients get older, AF recurs continuously like this. In this study, we analyzed the characteristics of patients with first recurrence after 5 years of catheter ablation. And upper patient showed a recurred atrial fibrillation 7 months after the procedure. But the low panel patient had the first recurrence 7 years after. The patient with first recurrence after 5 years had a relatively low LA voltage, but smaller left atrium at de novo procedures. And the characteristics of these very late recurrence patients was that the rate of extra PV trigger increased remarkably on the rhythm mapping. It suggests that although PV isolation was well maintained, extra PV triggers by atrial fibrillation progression may have contributed to the recurrence mechanism. We compare the rhythm mapping finding depending on the recurrent timing within a year, 1 and 3 years, and after 3 years. Smaller number of period reconnections as later timing of recurrence after de novo procedures, but more common extra PV triggers at the later timing of recurrence. This study found extra PV triggers in 12% of de novo and 29% of rhythm procedures. And over 30% of extra PV foci at rhythm procedure matched to previously done empirical left atrial ablation sites. So a necessary extra PV ablation at de novo potentially contribute to the recurrence mechanism. As you expected, rhythm outcome was worse in patients with extra PV trigger in both and de novo and repeat procedures. And it was even worse in patients with multiple extra PV triggers than those with a single trigger. Provocation and mapping method of extra PV triggers. Mapping and ablation of extra PV trigger are not that simple. After PV isolation, we give the isoproteron 3 to 20 mic per minute until heart rate exceeds 120. After reaching heart rate 120 beat per minute, we induce the atrial fibrillation by ramp pacing, and after maintaining the atrial fibrillation for 3 minutes until intracellular calcium level elevation, we deliver the internal cardioversion shock and wait for the immediate recurrence of atrial fibrillation for 10 minutes. If there is a frequent and consistent APC, we wait for AF reinitiation, putting the multi-electrode catheter near the potential extra PV trigger site. Although isoproteron provocation is the gold standard to map the extra PV triggers, some other EP labs use adenosine. And in this study, 2DNO compared the effect by isoproteron and adenosine in 40 patients with proximal AFib. At the same condition, isoproteron provoked extra PV foci in 7%, but adenosine induced 50%, mostly from RA and CS. However, adenosine-induced triggers of a non-PV trigger did not show any prognostic value in this study. Where are the locations of extra PV triggers in de novo procedures? This is Santangeli's report that there were 11% of extra PV triggers, regardless of a paroxysmal, persistent, or long-standing persistent AFib. The common site of extra PV foci were SVC, crista, chronic sinus mitral annulus, and septum. In our database, with over 2,000 patients, extra PV triggers were mappable in 12% at de novo, and the common sites were consistent to Santangeli's report: septum, SVC, chronic sinus. Long time ago, we proved the more commonly found extra PV triggers in a patient with persistent AFib than in proximal AFib. We cannot classify the location of extra PV foci depending on the LA volume index, although they counted the AF triggering foci and non-PV atrial premature beat altogether in this study. The proportion of non-PV foci was significantly higher in AF patients with larger LA size than smaller one. It was consistent in interatrial septum, CS, or left atrium. However, SBC trigger was more commonly found in smaller LA size, smaller LA patients exceptionally. Let's think about the potential mechanism of extra PB triggers. In this study, we co-localized the location of extra PB trigger and low voltage area, and we found extra PB trigger located in the area of a low voltage zone in 44%, but not in remainder. The co-localization with low voltage area did not affect the outcome of AF population. Depending on the site of extra PB trigger, RA and septal trigger shows a worse rhythm outcome than those of LA or An extra PB trigger also has an association with cardiac autonomic neural activity, and patients with extra PB triggers shows a significantly higher RMSSD at heart rate variability, and these patients with high RMSSD shows a higher number of extra PB trigger at redo procedures. An extra PB trigger also have a genetic background of zinc finger HOMBOX3 gene, and this gene is the top second AF-associated genome and associated with inflammation and fibrosis. AF rhythm outcome is worse in women after both de novo and repeat procedure. In the Cox regression analysis, worse rhythm outcome over repeat ablation was independently associated with women, non-proximal AP, and extra PB triggers. So women and extra PB triggers are poorer prognostic factor after AF ablation. Now, is extra PB trigger ablation really valuable? In this study, Tohoku provoked the extra PB foci by isoproterenol and adenosine together and tried to eliminate all the extra PB trigger, even atrial premature beats. After this aggressive ablation protocol in 300 patients with persistent AP, rhythm outcome was equivalent to those without extra PB foci, but the recurrence rate was significantly higher in patients with remaining extra PB foci or atrial premature beat. Takayama's study had a similar design, but no extra PB trigger ablation and just follow-up. In this study, the existence of extra PB trigger suggests a poor rhythm outcome, but frequent APV by provocation did not. During isoproterenol cooling down period, you can apply 3D quick map using the multi-electrode catheter to localize extra PB foci. However, you need to make sure extra PB foci localized on 3D map is just endocardial axis side. Sometimes it comes from the epicardial layer away from the endocardial axis side. We previously reported isoproterenol provocation and trigger ablation shows the better rhythm outcome than just finishing a case without isoproterenol provocation. However, those with extra PB triggers shows a worse rhythm outcome than those without trigger, even after additional ablation. And Professor Young Kim's group published the excellent RCT, which proved the value of isoproterenol provocation and extra PB trigger ablation. In this study, elimination of extra PB triggers improved the long-term rhythm outcome after persistent AP ablation. This is 2017 HRS-ERA AP-HRS guidelines for extra PB trigger ablation, and reproducible focal trigger ablation is class 2A indication. However, linear, voltage-guided, CAFE, rotational reentry, and GP ablations are classified as class 2B indications. How differs cryo PBI from RF PBI in terms of extra PB trigger? This study compared the outcome of cryo PBI versus RF wide circumference PBI in 1,500 patients with proximal AP. Although rhythm outcome did not differ between two groups, RF PBI group achieved a wide PB isolation. In the repeat mapping procedure, PB reconnection rate was significantly higher in RF group, but non-PB trigger was more commonly found in cryo group. These extra PB trigger after cryo PBI might be originate from these intra-PB areas not covered by cryo balloon. We also compare the cryo PBI and hyper-short duration RF PBI after propensity score matching. And although long-term rhythm outcome did not differ, prior PBI showed a higher recurrence rate in patients with large LFT2. It may be because 28 mm fixed diet cryoballoon spares some area of PBI antrum in large LA patients in this computation modeling study. Lastly, enterosmic drug response to extra PV trigger. In this study, inferior rhythm outcome in patients with extra PV trigger disappears after using enterosmic drug, and also inferior rhythm outcome with post-ablation high RMSSD also disappeared after using enterosmic drug. These findings suggest enterosmic drug suppresses extra PV trigger and ANS-related AF triggers. Women shows the inferior rhythm outcome after de novo and rhythm ablation compared to men. However, enterosmic drug response after post-ablation recurrence shows an opposite sex difference. Women shows a better rhythm outcome to enterosmic drug. These findings suggest enterosmic drug might be effective in controlling extra PV triggers, which is predominant in women. Okay, in conclusion, ladies and gentlemen, the patient with extra PV triggers show worse rhythm outcome. Isoproteral provocation and extra PV trigger ablation are valuable to improve the rhythm outcome of catheter ablation, but atrial premature beat ablation is not. Extra PV triggers have genetic background and play a major role in AF recurrence after catheter ablation, especially in women, very late recurrence, persistent AFib, larger LA, and after empirical extra PV ablations. Extra PV triggers could be associated with autonomic neural activity and controlled by enterosmic drug partially. And AF is not a curable disease, and the empirical extra PV LA ablation should refrain without clinical evidence. Thank you very much for your attention.